Hi, this is John Wasson. This is YouTube number 3, what we call the 10 bare bones slide for the Institute for Ideal Medical Home. This series of slides is brought to us primarily by the Institute for Healthcare Improvement and the many tests that we participated in there and in our Ideal Medical Practice project, where basically we kept boiling slides down and asking our so-called customers, in other words, folks like you and me, what seemed to work the best. And these are they. This first slide reminds us as we think about making changes in our practice, such as the PDSA or Plan, Do, Study, Act type cycles, we should take into account how confident we are the changes will lead to improvement and the risks of failure in our system and the resistance in our system. We believe that we operate in this Institute for Ideal Medical Home program in the lower area where we know these things will work. You just have to decide on how resistant your practice is. In the Institute for Ideal Medical Home, the ultimate measure of success is our patients reporting that they get exactly the care they want and need exactly when and how they want and need it. This is a driver diagram which basically points out the factors or drivers that are most critical in attaining that ultimate objective. The patient and family drivers being first, provider care team drivers being second, the leadership drivers being third in the diagram, but all of them have to work in synergy. Ultimately, these are all dependent on an underlying structure of reliability and safety, which we will describe in detail in just a moment. This driver diagram is critical to all our activities. Look at it, study it well. The two previous diagrams are pretty macro. Now we get down to the nitty-gritty of change. To get a patient driver, to get the patient engaged, we have to become much more behaviorally sophisticated than we've been in the past. We have to recognize that just handing out a brochure alone is not a way to define good information. The key is changing the patient's motivation, helping them with self-efficacy or confidence, as we've shown previously, and taking into account the other psychosocial factors or contexts that help or impede our change. We all know from our New Year's resolutions how difficult behavioral change can be, and the concept of making behavioral motivation and change a part of everyday practice is frightening to many clinicians because the idea is that it'll take a huge amount of time. Throughout this course, we will be introducing tools such as Care Vital Signs, which have a dramatic time-saving and behavioral moving effect on patients. And we'll hope that the practices will try them in the spirit of PDSA. In any practice that has more than a single physician, there is the potential for having a care team. And a functional care team makes a huge, huge difference on the outcomes the patient will experience. What makes a good care team? Here are the principles that have been found to be very useful for making a team highly functional. We will go through them over time, but we ask that a practice look at them now and think about their own work and their baseline assessment and how they might make the team better. Although a small health system may spend only a few months to get access right, a large health system can spend easily 6 months trying to get it right following these principles. In this course, clearly, we're not going to change access dramatically, but practices, particularly those guided by their baseline surveys to have to work on access, will be able to think about the principles and discuss them with others as they make changes and move toward more advanced access. Again, these are the principles, if you will, the checklist that every practice should go down as they think about access. Just like access, efficiency is a journey, not a destination attained in 6 weeks of this course. This checklist is very useful for all practices, large and small, to think about as they work on efficiency. We will be providing additional very helpful tools as well in just a few sessions from now. The point, again, of efficiency and access is they go quite well together as concepts in the driver diagram for practices that want to really improve care. Practices that have attained exemplary results over the years often comment that it was this diagram that put them over the top. Why? Because reliability is really an important underpinning concept to access, efficiency, and everything else a practice does. Clearly, if you're highly reliable, you're safe, but it's this checklist of strategies that they find so useful to think about backwards and forwards as they work through the checklists, if you will, that we've shown previously. We'll be returning to this often throughout the remainder of the course. In the driver diagram, we talked about leadership. In a small micro practice, clearly the single clinician may be the leader, and this slide may seem superfluous. But for any other practice above a solo size, it's very important for leadership, however it is defined, to have thought through the strategies and approaches that they'll have to use to make sure that the PDSA and changes envisioned in this course, promoted in this course, really take place and really spread throughout the organization. By this point, practices who've enrolled in the Institute for Ideal Medical Home may feel overwhelmed, almost exhausted by thinking about the checklists we've shown, the key points that will make their practices really good. This slide reminds us that the journey need not be exhausting at all if the patient is engaged as a partner in these activities. The patient is truly the center because it's axiomatic, because it motivates us to do better, but also because it's just very practical and a way for us to make change. Throughout this course, we'll emphasize the importance of the patient as a source of information to help us.